Sir has asked me to give an introduction to approach to salivary glands in relevance to undergraduates. So, sir has asked me to give us slides, probably 15 to 20, but I made a huge mistake. It is 47 slides, but I will definitely curtail. So, I made a point to prepare a slide which could be relevant for across many sessions, so that I asked my postgraduate to prepare yesterday. He said 47 slides, but I will give you what is essential for you as an undergraduate, stressing upon important things. All of you could have completed surgery posting one round, is it? One round mudichirupanga illaya? One round mudichirupinga. One round now. You have two rotations of second round. They are in second round. So first round is over. Anything, any have doubts, please ask me. Otherwise, I will just present this session. Then we can have discussions during our immediate. So I have just divided my topic, an approach to salivary gland introduction. In that we will say what are salivary glands, what are major salivary glands, how relevant are they clinically in disease presentation, what relevant history you must ask in salivary glands to come to a conclusion, essentials of examination, and when you present with a salivary gland problem, what is the diagnostic approach and management. I may not touch much on management, which consumes around 15-20 slides. So, all of us know there are major salivary glands and minor salivary glands. The major salivary glands are paired organs. They are parotid, submandibular and sublingual. And the minor salivary glands are around 600 to 800 glands. They are present in mucosa of oral cavity, oropharynx, hypopharynx, lip, buccal mucosa and palatine. Salivary glands are also present in areas such as maxillary antrum, nasopharynx, larynx and trachea and esophagus. You can have tumors. Adenoid cystic carcinoma can occur in the esophagus. So these are also in ectopic situations because they commonly develop from aerodigestive embryology. So you can have salivary gland tumors from these regions also. Forget all those. You have major salivary glands and minor salivary glands. In general, the tumors of minor salivary glands are rare. If they occur, the chances of them being malignant is huge. When it occurs in a benign major salivary gland, the chances of it being benign is high. When it occurs in a minor salivary gland, the chances of it being malignant is high. So this is the message. So this is a diagram which can tell. I am not able to use a pointer because of the LED projection. You just know the parotid region, you have a huge gland which is parotid, then you have a parotid duct and you have the sublingual gland, submandibular gland. One muscle which is relevant to parotid is, which muscle is relevant to parotid? Masseter. So masseter is the one which is which muscle is in relevance to submandibular? Mylohyoid. Fantastic. So these two muscles are in relevance. I will just go through further into each of those. What salivary glands? Parotid is the largest salivary gland. It produces 30% of salivary volume. The next major salivary gland, again a paired gland, is a submandibular salivary gland, which is a mixed salivary gland, but it produces more mucinous secretion in comparison to your parotid, and you have sublingual which contribute. In terms of volume of secretion, 30% is from parotid, 60% from submandibular and 5% from your minor sublingual glands. Rest are from minor salivary glands. Only one relevance, serous secretion from parotid, mucinous secretion to a great extent from submandibular. What is the relevance? It's the largest salivary glands. It is divided into two lobes by the facial nerve. The lobes of parotid are not anatomical lobes. They are surgical lobes because there is no plane fascia or muscle which separates the superficial and deep lobe. So it is only a surgical lobe. It is named after, it is called faciovenous plane of Patty. Faciovenous plane of Patty. The large portion of the parotid is superficial lobe, which contributes 80%, and the lesser portion is 20% your deep lobe. You can see in the pictorial representation, yellow structure is always denoting a nerve, that is a facial nerve. Then you have got the retromandibular vein, that deepmost structure is the external carotid artery. My teacher, as a surgeon, he taught me in parotid, if there is a major bleeding in parotid, he says, you have already transgressed the facial nerve. He asked me to remember by saying, if there is, you paralyze before you bleed. You paralyze before you bleed. What does it mean? You would have gone through the facial nerve if there is a torrential bleeding, because nowhere else in general, now like superficial, challenging a surgeon to do a surgery. So that's a pictorial representation. In that you have the graph, that diagram is parotid duct. What is the name of the parotid duct? Yeah, Stenson's. Your students are brilliant, sir. So Stenson's duct, please understand, it is not important you know the latest concept. You should know the basic and strong anatomy which is relevant, which is evergreen. All investigations will change. So you must have, as a surgeon, anatomy is the basis of, to make you a good surgeon. So there is the duct which is called a Wharton's duct. It runs upon the masseter muscle and which opens along the crown of upper second molar. So this beautiful diagram represents parotid, that is the Stenson's duct, runs along the masseter, opens upon the surface, crown, opposite the crown of upper second molar. Then you have the next salivary gland, you have the submandibular salivary gland. The diaphragm of submandibular salivary gland is the mylohyoid muscle, which also opens by a duct named as Wharton's duct. And you have got next major salivary gland, which is smallest in size among the three, is the sublingual salivary gland, which drains by multiple ducts. You can see that in the pictorial representation. So this picture is exclusively stress the importance of facial nerve. Facial nerve is characteristically, in this picture you have got pes anserinus. Facial nerve comes out of the skull through the stylomastoid foramen. The word in Bailey which describes it becomes rapidly superficial. From skull to reach the back of parotid, it becomes rapidly superficial. What does it mean? You have to be very careful at the stylomastoid foramen, because the nerve will enter the posterior aspect of the gland. It starts branching inside the gland into upper and the lower division. The upper division has got a temporal, zygomatic, buccal. The lower division has got two. They are mandibular and cervical branches. Which branch is the most important of all? If you have to preserve one nerve, you are cursed with parotid in a surgery with paralysis, which branch you will pray for to be preserved? Buccal. You have to preserve the branch which supplies the orbicularis oculi. Rest of the functions are easy acceptable. So this is the characteristic diagram which represents the facial nerve. Parotid, the gland which grows first among the salivary glands is the parotid. Parotid grows very early. The nerve and other, that is why it engulfs the nerves, comparison to submandibular. These are all for postgraduates. Anyway, I am not able to limit myself, just overshooting. So whenever you have got a unilateral parotid swelling, the commonest parotid swelling which occurs in a postoperative patient is a acute parotitis, which occurs in a postoperative setting. The another parotitis is sialolith, is not common in parotid, but for completion's sake you are saying. But what is the commonest swelling which involves parotid viral infection? Mumps. It is tend to be bilateral. The next thing is benign and malignant neoplasms of the salivary gland. Parotid. This is what epidemic parotitis or mumps, Sjogren syndrome, which produces bilateral parotid enlargement, Mikulicz, all these things are very, very rare. Metabolic sialadenosis, that you must remember. These are common because these diseases are common. Take diabetes mellitus, nutritional deficiency and liver alcoholism. In alcoholics, if you see, you have bilateral parotid enlargement, which is not pathological. So that is called metabolic sialadenosis, diabetes, nutritional deficiency, alcoholics and CLD. So anatomy of submandibular salivary gland. Submandibular salivary gland, as it implies, it lies in the submandibular triangle, which is bounded by the which muscle? Which muscle bounds the submandibular? What is that muscle which runs here? Digastric. So submandibular salivary gland is divided into a superficial and a deep lobe by a muscle which forms a diaphragm. What is that? Mylohyoid muscle. So the lobe in parotid is a surgical lobe, but whereas the lobe in submandibular is a anatomical lobe because it is divided by the mylohyoid. So the nerve which winds round, there is another nerve which is very closely intertwined with submandibular. What are the nerves in relation to submandibular? Lingual and hypoglossal. Lingual and hypoglossal nerve. These things you must remember. So unilateral, what is the differential diagnosis for submandibular swelling? If suppose somebody has got a submandibular swelling, what is the differential diagnosis? What is the commonest swelling in the neck? Suppose somebody has got, ask you, which is the commonest swelling of neck? The commonest swelling in the neck is a lymph node, unless commonest swelling in the neck is a lymph node, because there are 600 to 800 nodes in the body, of which 300 nodes are there in the neck. Two philosophies you must remember. One, the commonest swelling in the neck is a lymph node unless proved otherwise. The second philosophy is any swelling in the region of a lymph node is a lymph node unless proved otherwise. Any other swelling which occurs in the region is only a second diagnosis. So the neck being such a common site, head and neck, you have got submandibular region has got submandibular lymph node. So the differential diagnosis for submandibular sialadenitis or submandibular adenopathy is lymphadenopathy, submandibular lymph nodes enlargement. How will you differentiate? Can anybody tell me? So this is submandibular gland. The sialadenitis is more common in submandibular salivary gland for the reasons 80% of the submandibular gland and 20 in parotid. The reason being submandibular gland has got a more mucinous secretion, then it has got a non-dependent drainage, and the calcium content of the submandibular salivary gland is huge. So the stone disease is almost always the disease of submandibular salivary gland, which is not very common in parotid salivary gland. This is the picture. Arrow depicts a stone at the orifice of a Wharton's duct. Can you see that white dot? We have right now in our ward a patient who's got a 3 by 1 centimeter salivary gland calculus we are planning to operate. Huge one. So this is the characteristic site for a submandibular, the arrow marks the size for a submandibular salivary gland enlargement, and rest of things you don't have to. What is sialactasis? Dilatation of salivary ductule with saliva can form a retention cyst, that is called as sialactasis. This diagram is to make you aware the incision which you make in the region of parotid for draining an abscess or excision of a tumor should be in line with the helix. So it should be in line with the helix, must be careful in your approach. This is called blast incision. What we use is a modified Blair incision. Parotid fistula, I just don't want to know. Inadvertent opening of a parotid abscess or in the presence of an obstruction can produce parotid fistula. This is just to know. So what are the things you will ask? Suppose somebody has come to you with a parotid swelling or a swelling in the region of parotid, or somebody has got a swelling in the submandibular region. What are the things? Anything in general you ask for. Where is the swelling started? How it progressed? What are the associated things? Is it associated with pain? And in this region, the locoregional function is opening of the jaw and mastication. Is there any trismus? One peculiar thing which is relevant, which you can ask, is meal time increase in size of the swelling. Meal time increase in salivary. That is called salivary colic. Colic is a pain which occurs usually in a luminal organ. You can have ureteric colic, you can have intestinal colic, you can have salivary colic, biliary colic and salivary colic. When a duct is blocked, you get intermittent pain. That's more during eating. That's called salivary colic, which when after few hours of eating, the pain automatically subsides. You can ask for dryness of mouth, which is Sjogren's, which I have not seen one. And you must ask or look for, patients themselves will say facial weakness. I repeatedly insist telling my students, before you start asking, ask the patient to talk more. Of the two, patient and doctor, patient is more intelligent than us. Listen to him, we will make a diagnosis. If you start talking first, he will stop talking. You will not be able to get valid point to make a diagnosis. Previous history of virus infection and radiation. Current medication, lot of drugs are known to produce salivary enlargement. I am not getting into those. Examination. If you just look at asymmetry of face, why is this important? In a patient with parotid and it's got a facial nerve involvement, you can have asymmetry of face. And characteristically, you say lifting of your lobule. All of us will say the characteristic sign of a parotid. You can have node in the parotid region also. Parotid is rich in lymph nodes. There are lymph nodes inside the parotid gland. So, though there are a lot of nodes inside the parotid gland also, so you must be the one which lifts the hair lobule is characteristic feature of a parotid swelling, and obliteration of retromandibular groove because of the anatomical position of the gland. Then you can say trismus is not a feature of that common a feature because malignancy is not that common, and you must examine the oral cavity. Why should you examine for medial displacement of tonsil? Why should you look for medial displacement of tonsil in a parotid? Deep lobe involvement. Deep lobe is though small, when it enlarges in the parapharyngeal space. When it enlarges in the parapharyngeal space, it pushes the tonsil medially, and you must look for facial nerve involvement branch-wise, and in case of submandibular, you must look for hypoglossal. Suppose if there is a right side parotid enlargement and malignancy, parotid, submandibular, and the nerve is paralyzed or infiltrated, the tongue will give it to which side? There is a unilateral hypoglossal nerve, same side, because it's pushed by the opposite side. Fantastic. Better say other side. Opposite side is the person in front. It is becoming more irrelevant if you examine a breast and scrotum and say opposite is in front. You should always say the other side or contralateral is correct terminology. Never say opposite side. Opposite is right in front. If your examiner is sitting in front and say opposite, you mean differently. It's better say other side and contralateral side. So get used to it. So this is a pleomorphic adenoma which pushes the tonsil medial. Palpation, start with warmth, tenderness. Start with warmth and tenderness. If you make a basic mistake on warmth and tenderness, you will make a miserable mistake. You can never recover. So look for those things. The next one is the curtain sign. Why curtain sign? Because the parotid fascia fixes itself to the, so it cannot go, but that's a curtain sign which is being demonstrated. Intraoral examination to look for lymph lobe enlargement and lymph node examination. Curtain sign I have just told you. Extraoral examination, you just start examining the face, look for size, shape, surface, skin consistency, and examination of muscles, fixed to the masseter, TM joint, all those things you can examine, and examine for the motor functions of the facial nerve. There are certain organs which need to be examined by bimanual. If you use hands to do, it's called bimanual examination. If you use your digits to do by digital examination, you may, in the case of parotid, you have to put your finger inside the mouth and keep just behind the retromandibular trigone, the anterior pillar of tonsil, another finger just behind the mandible and the retromandibular. Try to push and look for deep lobe involvement. And in case of submandibular duct and submandibular salivary gland, I have told you, I have missed that point. The submandibular salivary gland has got a superficial and a deep lobe. Silidinitis, when it involves both the superficial and the deep lobe. You will start feeling the gland bidigitally, whereas submandibular lymph node will not be bidigitally palpable, which is above the mylohyoid diaphragm. So the one which is bidigitally palpable is submandibular salivary gland. One which is not palpable is the node. Second thing, you can roll over a submandibular node onto the mandible because it is not fixed to anything. Whereas salivary gland cannot be rolled over because it is wedged by the mylohyoid muscle. So these are the 2 points which differentiate a submandibular salivary gland from a submandibular lymph node. Bidigital examination is to confirm and also examine the duct, looking for calculus. You have to examine the facial nerve, the nasolabial fold, furrows, and all that examination we do for a Bell's palsy. And this is a diagram which says facial nerve, which is demonstrated just in front of the tragus. The facial nerve, there are postgraduates. The facial nerve, the easiest and the correct method of identifying the facial nerve is the tragal pointer, which lies 1 centimeter infromedial to the tragal pointer. The most consistent place you can ever find the facial nerve is 1 centimeter infromedial to the, there are many methods of identifying. The easiest and the safest is tragal pointer 1 centimeter infromedial. It is covered, the tragus is dissected, you can see the nerve. This is our own picture. Signs which suggests malignancy, general malignancy அப்படின்னு சொன்னாலே என்ன அர்த்தம்? Yes, printed sudden increase in size, should not call it a sudden increase in size, you should say rapid increase in size. Sudden increase in size can be called by a rapid accumulation of fluid or air. So you should not say that. Ideal terminology is rapid increase in size. Whenever the patient, there is appearance of pain or paralysis because there are a lot of nerves, when the patient has got skin fixity, muscle fixity, bone fixity, trismus, difficulty in swallowing, when there is a deep lobe enlargement, facial involvement, all these are signs. In addition, can produce neck nodes. There is a mucoepidermoid carcinoma. That means there is epidermal element. Whenever there is a squamous cell element, it will always go to the nodes. So these are some of the features of parotid malignancy or salivary malignancy. So investigations, I always insist, my teaching is to say, my own teachers, 3 categories of, don't say general and specific. What is general in one category becomes specific in another category. So they are relevant, you can classify them into 2 categories. One is to confirm the diagnosis. Second is to stage the disease. What is the stage? Even hypertension has got stage, diabetes has got stage, CKD has got stage, malignancy malignancy has also got stage. To stage the disease, to assess the general condition of the patient. How is he fit? These are the categories. What are the specific investigations specific to parotid, means salivary glands is technetium-99 scan, X-ray for sialatinosis and sialography. These are all specific only to salivary gland. So what investigations you will do? You do all these investigations, the confirmatory investigations in general. What is that test you do if there is a swelling in the salivary gland? Which first test you will do? Somebody has come to your OP, you are sitting as a CRMI, and somebody, what test you will do? The best first test you can do is an ultrasound. Ultrasound is so patient friendly, it can be repeated, but it is observer dependent. It will tell you what is the tumor, is it solid or cystic, nodes can also be assessed, vascularity can be assessed. Then you can do a FNAC. When we were students, FNAC was contraindicated in parotid. If you say FNAC, we would have got fail. Nowadays, we will not, because FNACs and targeted FNACs are very specific. In fact, they can make a diagnosis. And second thing, CT scan and MRI. CT scan and MRI are very, very relevant nowadays, not in small tumors, tumors which are large, tumors where you suspect malignancy, tumors which arise from deep lobe, tumors have got clinical signs of malignancy. The 2 things which are CT is useful for assessing the cortical bone erosion, and CT is useful for assessing neck nodes. That is more specific. MRI is useful for assessing the soft tissue or tumor assessment. It can also assess skull base. MRI can assess medullary bone involvement. MRI can assess perineural and lymphovascular assessment can be made by MRI. So don't say because I have done CT I will not do MRI, because model treatment and classifications do involve radiological investigations in clinical staging, because the treatment can be grossly wrong. So US guided core biopsy in certain situations. So as a student, if you ask you, I will do ultrasound, I will do FNAC. When you do CT and MRI, I will do in a larger tumor. As an undergraduate, that is more than sufficient. I have given you points which are relevant. FNAC has got high sensitivity because highly cellular, but it can identify malignancy, anything. Majority of the problems can be diagnosed by FNAC. As I have told you, CT and MRI are not indicated in small mobile masses. They are indicated in larger tumor where suspect malignancy. So once you coming to the treatment of our, just touching outline on things. Suppose if there are stones in the duct, a duct stone can be removed under local anesthesia by making an incision over the duct and removing the stone. A gland stone has to be removed. Majority of the time it involves removal of the entire gland. Chronic sialadenitis lead to excision of the entire gland. Parotid abscess. There are certain areas in the body you don't wait for fluctuation to develop. Generally abscess are drained after clinical signs of fluctuation. In modern day ultrasound will tell you. But certain areas you don't wait for fluctuation. One such abscess is parotid, breast, plantar abscess and palmar abscess and ischiorectal abscess. You don't wait for fluctuation to develop. If you wait for fluctuation to develop, it will destroy the entire gland and patient may sometimes develop facial edema, facial nerve edema and facial palsy. These are all not for you. I don't want to get into this. Parotid tumors. At the end of this session, if you have to carry some message in relation to tumors of salivary glands, 80% of the tumors of the salivary glands arise from which gland? 80, parotid, of which 80% are pleomorphic adenoma. What does it mean? 60% of the times you will be operating on parotid in a salivary gland tumor. If it occurs in a submandibular salivary gland, the proportion of benign and malignancy changes towards malignancy. But if it happens, if there is a benign tumor, it's still more common tumor, benign tumor of submandibular is pleomorphic adenoma. As you go to the minor salivary glands, if it is benign, almost always pleomorphic adenoma. But it is very, very rarely possible for you to have a benign tumor of minor salivary glands. We usually keep minor salivary gland tumors in the medal exam for postgraduates. So, minor salivary gland tumors are almost always malignant. The incidence shifts to the submandibular. The least malignancy is in parotid. The most common tumor of parotid, in the case vechalum pleomorphic adenoma nu soltingna tapchidalam. So, it is not no issue at all. You just say pleomorphic adenoma, nobody will be able to fail you. So, what is determines you have to do a superficial parotidectomy. See, whenever we were students, the minimum surgery in thyroid is, what is minimum surgery in thyroid? No, it has changed, now shifted to total thyroidectomy. The minimum surgery in thyroid is semithyroidectomy. The minimum surgery in parotid is superficial parotidectomy with a class of ECN, ECD which is becoming rare, extracapsular dissection. I will tell you differently, but minimum surgery in thyroid is hemi and minimum surgery in parotid is superficial parotidectomy. So, what is superficial parotidectomy? Removing the entire parotid which is above the plane of faciovenous plane of Patty or the facial nerve is called superficial parotidectomy. In malignancy, total parotidectomy, the more apt word will be a radical parotidectomy, excising the parotid as well as the related lymphatics and lymph nodes, an extended radical if you involve muscle fat and fascia. Facial nerve, always you are more and more into organ preservation and functional preservation. Unless the facial nerve is grossly involved, engulfed or to certain extent infiltrated, you should not sacrifice a facial nerve. It is better to leave a sleeve of tissue around and can irradiate. The concept is facial nerve preservation in case of malignancy. Even if you remove, the prognosis may not be good in some such situations. So, extracapsular dissections, it is not done for deep lobe tumors. So, latest concept you should know as a UG student, but in all gustatory sweating, you can remember the problem by gustatory sweating. As you start tasting food, start sweating there. So, these can be avoided by extracapsular dissection or wide local excision. Total conservative parotidectomy is done for a relatively pleomorphic, deep lobe pleomorphic adenoma or superficial lobe extending into the deep lobe. So, neck nodes, what you do for the neck nodes? Neck nodes need to be managed according to their involvement. I am not going into those because of the relevance for undergraduates may not be resident. Mucoepidermoid carcinoma, the commonest malignancy of parotid is, salivary gland is mucoepidermoid carcinoma. If anybody asks you which is the commonest neoplasm of salivary glands, it is mucoepidermoid carcinoma. So it has got stages, got low grade, intermediate grade and high grade. It also requires radical parotidectomy and the lymph node dissection and radiotherapy and chemotherapy. The next variety of carcinoma is adenoid cystic carcinoma. The adenoid cystic carcinoma has got a peculiar tendency to go along the perineural invasion, and also lymphovascular invasion is also common. It can involve it can travel along now for a long distance. Even a small tumor can produce paralysis and parastasis. That is a speciality of adenoid. That is the worst nature of, not speciality, worst nature of adenoid cystic carcinoma. And it also requires excision, tendency for perineural invasion, and it is very difficult to cure because it would have metastasized if it is large. So radiotherapy in general, wherever you give radiotherapy, it's easy to remember. Whenever you have got a residual disease, whenever you have done a surgery or something, it is recurring, or whenever there is refractory situations and residual disease, refractory disease and recurrent disease, you give radiotherapy. I don't want to get into those because of... One thing you remember, what are two types of radiotherapy? One is brachytherapy, another is teletherapy. Brachy is close. When the source is inside an organ or very close to an organ, it is called brachytherapy. Tele is distance. When the source of radiation is away from the tumor, it is called teletherapy. The drugs, chemotherapy, methotrexate, adriamycin, 5-fluorouracil and mitomyc. These are the drugs. I don't want to do all those things. If you have a tumor of submandibular salivary gland, again it is only a excision of a submandibular salivary gland, or it could be an extended resection or composite resection. Minor salivary gland, I have told you, are 80% are malignant. They will present as malignant. The commonest tumor of minor salivary gland, among the adenoid cystic carcinoma is more common in minor salivary gland, but the minor salivary gland tumors are not common. Remember, whenever you are asked about salivary gland tumor, remember two things: parotid and parotid. In case of submandibular, error on the side of adenitis. So these are all, for completion you must know all these things. I think probably I have completed on time. Thank you for patient hearing and thanks for your time. If you have any questions, I can, but it's a huge topic which I have rushed for sake of relevance. There are certain things which should say, as I have told you, in don't forget facial nerve in parotid. Second thing, parotid neoplasms are almost always pleomorphic adenoma. One entity which is not included is carcinoma X pleomorphic adenoma. Pleomorphic adenoma can also become malignant. That's called carcinoma X pleomorphic. I have not gone into the pathology and the details of those. In submandibular, you remember sialadenitis. In myelin salivary glands, malignant tumors are more common, and the surgery is becoming more and more less radical with adjuvant chemotherapy and radiotherapy. Facial nerve, never fail to examine, and these are the things I would like to insist. The worst complication is gastritis sweating or Frey syndrome. If you landed with one patient, you will never touch. Next time you touch a knife, you will fear a lot. Thank you again for patient hearing. Thank you. Any questions, I will answer during the next session along with my co-panelists. Thank you, sir.